Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOGS Endocrinology Committee. A warm welcome to all our respected faculty and dignitaries who are here for today's event. This is the first in a new series this year, 2023, the Experience Series, with the blessings of our seniors and our eminent faculty who are gathered here today. Today's program is on hypertensive disorders in pregnancy, and we have updated management strategies for all of you who've logged in, not only from India, from across the world. We have more than 800 registrations so far from more than 18 countries. So thank you very much for being here. Over the next couple of hours, we'll have very senior and eminent clinicians talking about the updated management strategies in hypertensive disorders in pregnancy. But before we begin, as is customary, next slide, please. I would like to place on record my gratitude. Next slide. To our AMOGS office bearers, Dr. Rajendra Singh Pardeshi, sir, who's the president of AMOGS. Next slide. To Dr. Sujata Dalvi, our secretary of AMOGS. The chairperson of ICOG, Dr. Lakshmi Shrikhande, and the secretary of ICOG. Next slide. Dr. Ashok Kumar, they have granted us the ICOG credit point for this event. Thank you very much, sir and madam. Next slide, please. We have Dr. Sujata Dalvi, who is the secretary of AMOGS, and she will be here as a chairperson for today's event. We are delighted to welcome her. Next slide. Dr. Bharti Maheshwari is the past chair of the FOXY MTP committee, and she has done fantastic work during her tenure as chairperson of that committee. We are delighted to welcome her as a chairperson. Next slide. We have two fantastic speakers in the shape of Dr. Charmila from the South. She's a vice president-elect of FOXY. Next slide. And Dr. Suchitra Pandit, madam, who is the past president of FOXY, Mumbai Society, and the Gestosis Organization in India. Thank you very much for joining us. Let me formally introduce Dr. Rajendra Singh Pardeshi, sir. Sir is the president of AMOGS. He served as the president of FOXY in the past. He was there with us throughout the pandemic, and he gave us a lot of support and encouragement when I did my series during the pandemic. He was there for almost every single program as a chairperson or a guest of honor or a chief guest for my events. Sir has the unique distinction of winning several prizes at ASCOG conferences. Over to you, sir.
Yes. Good afternoon, everybody. Respected ICOG chairperson, Dr. Lakshmi Shrikhande, ICOG secretary, Dr. Ashok Kumar, our AMOGS secretary, Dr. Sujata Dalvi, our past president, FOXY, Dr. Suchitra Pandit, and FOXY VP-elect, Dr. Charmila, and our ever-active chairperson, Dr. Pratik Tambe, and Bharti Maheshwari. As all known that SDP, preeclampsia contributes around 15 to 20% of maternal mortality. As you know, in 1990, the maternal mortality rate was around 560 per 1 lakh deliveries. WHO FIGO has given target of reducing MMR to less than 70 in 2030. But now India, MMR is 103. But I can say proudly, I can announce that our Maharashtra MMR is 38 now. I think this year, Pratik, it's reduced to 33. And now with the contribution of all our members, all our FOXians and AMOGsians, we can surely take a challenge to reduce to a single-digit number. And with two giant speakers, Dr. Suchitra Pandit and Dr. Charmila Ayyavoo, this will again help to reduce MMR. I congratulate Dr. Pratik Tambe, chairperson of our AMOGS Endocrinology Committee, for this continuous efforts. His continuous efforts to achieve, and I think this also helps to reach our MMR goal with these types of activities. I wish every success to this webinar. I wish every success to Dr. Bharti Maheshwari also for her future endeavor in FOXY.
Thank you.
Thank you so much for inviting me. Thank you so much.
Thank you very much, sir, for being here and for gracing the occasion. Thank you very much for your blessings, and we will need your blessings to continue in our efforts in the future of the series as well. To formally introduce Dr. Sujata Devi ma'am, she's a consultant OB/GYN at several hospitals in South Mumbai. She's an honorary clinical associate at the Nauroji Wadia Maternity Hospital. As I already said, she's the secretary of AMOGS currently, and she's the joint assistant editor of Jogi, which is the Foxy journal. She's an office bearer of the Mumbai Society. We're delighted to have her here in person. Thank you so much, ma'am, for joining us. I would request you to introduce our first speaker of the day, Dr. Charmila.
Yeah.
Sana, can we have the slide on screen, please?
Thank you, Dr. Pratik. I would just like to say few sentences that on behalf of AMOGS, I would like to acknowledge the constant encouragement given by our president, Dr. Rajendra Singh Pardesi, and I would like to express gratitude to Dr. Pratik Tambe, being an AMOGS endocrine chairperson, committee chairperson, for giving me an opportunity to be involved in this session and being a chairperson for this session. Today's topic is HDP. However hard you talk and so much you talk, but HDP is always a very important topic so far as obstetrics is concerned, and it's the highest most cause for maternal mortality. And we have two excellent speakers for today, Dr. Charmila and Dr. Suchitra Pandit, who are expertly in their own field, and they would give us a good guideline so far as HDP is concerned. Our first speaker is Dr. Charmila Ayyavoo, and she is going to be speaking on hypertensive disorders, the changing landscape. Can I have Charmila's? Charmila is a vice president-elect of Foxy 2024. She was a chairperson of Clinical Research Committee of Foxy in 2016 and 18. She is an ICOG governor, ICOG Governing Council member 2021 to 22, and she is a national coordinator for UNICEF Foxy PCA as well as PG program. She has been national coordinator for ISA Gurukul 2022, and she has been a past secretary of Trichy OB/GYN Society. So over to Dr. Charmila for her topic on hypertensive disorders, the changing landscape. Let us hear in from Dr. Charmila.
Thank you so much, Sujata ma'am, for that very kind introduction. I would like to pay my respects to Dr. Rajendra Singh Pardesi sir, who's a brother to me. He's guided me so much through the years. And like to welcome Dr. Bharati Mageshwari to the program, and special thanks to Dr. Pratik for giving me this opportunity to talk in AMOGS. Thank you so much for this opportunity. My talk is going to be on hypertensive disorders, the changing landscape. As both Sujata ma'am and Pardesi sir said, this disease is not going away from the obstetric scenario, and it's creating so much of havoc throughout in every part of obstetrics. So when you talk about the disorders, it's almost like it accounts for 14% of the global maternal deaths. It is the second leading cause, direct cause of maternal mortality after maternal hemorrhage. And when you talk about like how much it's prevalent in the community, it's, even though it said it's 4.6%, I would say it's grossly underreported, because almost like 10% of the pregnant population is affected by these hypertensive disorders as far as India is concerned. So when you want to define this disease, whenever there's a blood pressure which is higher than 140/90 millimeters of mercury, and when it happens before 20 weeks of gestation, and there is no proteinuria, it is labeled as chronic hypertension. But suppose there's proteinuria even before 20 weeks of gestation, and there's a rise in blood pressure, or there's a maternal organ dysfunction, then it becomes superimposed preeclampsia on chronic hypertension. When this disease happens after 20 weeks of pregnancy, and there is no proteinuria, it is a new onset hypertension after 20 weeks, and it's labeled as gestational hypertension. But when there's at least one of the following, which can be proteinuria, maternal organ dysfunction, if there's a doubling of the liver enzymes, AST or ALT, the patient has got pulmonary edema, or even uteroplacental dysfunction at this point of time, it's labeled as preeclampsia. But there are certain other varieties which has been actually put up in the International Society for Study of Hypertensive Disorders in 2018, and that they brought in white coat hypertension and masked hypertension. White coat hypertension is one where you diagnose increase in blood pressure in the office or clinic, but when the patient goes home, there's a normal domiciliary blood pressure recording. That is around 135/85. But do not take this lightly, because these patients also have got a higher risk for going into preeclampsia or eclampsia later on. So they need to be put a watch on. And there's the other variety called as the masked hypertension, where you got normal reading in the clinic, in the office, and even at home it will be normal. But when you put the patient on a 24-hour monitoring, you will find that the blood pressure is elevated at some point of time. And that is masked hypertension. These two are very important because these are ones which we miss usually, and the patient lands up with a complication later on. So these hypertensive disorders, that is one of the part of the changing landscape. You do not want to miss diagnosing white coat hypertension or masked hypertension, because you would have diagnosed preeclampsia, and when a complication happens, you will know. But the starting stages of these disorders, if you don't diagnose, it's going to cause complication. That's one changing landscape. And when we see the increasing incidence of this disease, it's almost increased by 25% in the United States, where there's a good documentation of this disease. And between 1987 to 2004, it's almost increased by 25%. And when you compare a lady who gave birth in 1980 and when she gave birth in 2003, there was almost a 6.7-fold increased risk of severity of preeclampsia, not even mild. The severe preeclampsia rate has increased almost 6.7-fold. And when you talk about the risk factors for this disease, we always talk about nulliparity, but remember primary paternity, the partner change will also cause this disease. And advanced maternal age is contributing to increased risk of this disease because mothers are getting married later, as well as previous preeclampsia is also contributing to a higher risk of preeclampsia in this pregnancy. The maternal corpulence, that is the higher body mass index of women now, is also contributing to a higher risk of preeclampsia. Higher risk of diabetes is there now, and so the other metabolic disorder, that is a cardiovascular component, also adds in and becomes preeclampsia during pregnancy. Multiple gestations because of infertility treatments is also contributing to a higher risk. Assisted reproductive technology, which is being used in so many cases now, is also contributing to a high risk of preeclampsia. And when the mother has a pre-existing medical condition, it seems to be much more common now because of the higher body mass index, diabetes, and advanced maternal age, they usually land up with pregnancy with chronic hypertension, or rarely they can have antiphospholipid antibody syndrome and renal disease too. So the prevalence of preeclampsia has got an increasing slope now, that the landscape has changed. And the factors which have contributed to this ascending trend of preeclampsia, according to the BMJ in 2013, is the use of assisted reproductive technology, the increased incidence of hypertension, diabetes, obesity in mothers, and also the early diagnosis problems, because you sometimes tend to miss the diagnosis in the earlier period, then the patient lands up with a complication later on. And these are all responsible for the ascending trend of preeclampsia prevalence now. And there's a difference in the economy also, which they found out now. Like in the high-income countries, the incidence is actually decreased, but in low-income countries, the incidence is actually increased. And the factors which has contributed to that, according to the 2018 article by Myron Kiss, the decreasing incidence in high-income countries is because of there's a good access to quality prenatal care. And when there's a patient who's got preeclampsia and eclampsia comes to the hospital, there's an adequate management which contributes to a decrease in incidence of the complications. But in low-income countries, the increase is probably because of reduced access to quality care and also because of the poor management of cases of preeclampsia and eclampsia. And the risk profile has also changed in the different countries. In developed countries, the incidence is more in low-risk nulliparous women because they pick up those high-risk cases quite early in primary para because the incidence is usually high there. And when they pick it up early, they manage it much more effectively. But when it happens in a multiparous women in a developed country, it's usually when they have a high-risk condition. So when they manage a high-risk condition better, these patients do not land up with severity of preeclampsia. And that is a change which has happened in developed countries, and it has not been seen in developing countries still. So when you define this disease, it's actually new onset hypertension, which arises after 20 weeks of gestation with multi-organ system development, and it should completely resolve with 12 weeks after birth. Proteinuria has been taken off from the definition of this disease now. So it's actually put up as multi-organ system involvement, because even without proteinuria, you can have the other organs getting involved, and that is also preeclampsia. So the changes in diagnostic criteria, the earlier criteria was a classical triad of hypertension, proteinuria, and edema, but now it is superseded with the definition of with hypertension and organ dysfunction, which can be renal, hepatic, hematological, neurological, or placental. And any of that organ dysfunction with hypertension is almost sufficient for a diagnosis. You do not need proteinuria or edema now, and that is a change which has happened in the diagnostic criteria. And proteinuria is not an essential condition. It's not a sine qua non condition to characterize preeclampsia as previously ensured. And the International Society for Studies on Gestational Hypertension, which was published in 2014 and again in 2018, reinforced the point that every hypertensive pregnant woman should be investigated for multiple organ involvement, even if she presents with negative proteinuria. So any patient, even if you think it's a mild hypertension, you will need to investigate for an organ involvement, even if proteinuria is not there. This approach is innovative, and it tends to encompass cases that are neglected by the absence of proteinuria. So the so-called atypical preeclampsia are not going to miss if you have this in your mind when you're investigating a patient with hypertension during pregnancy. So the pathophysiology in 1973, which was put up in the National Institutes of Health by the NIH, they put it up as it's primarily an ischemic disorder, and it affects the placenta, kidney, liver, and brain. And that was the pathophysiology then. But now the change is, it is more of a cellular immune response, which is having a pathology there, and that's contributing to preeclampsia. And the major cells which are involved in the pathogenesis are now thought to be in 2022 to be the regulatory T cells, the effector T cells, the NK cells, monocytes, macrophages, and neutrophils. So there's a change in pathophysiology which has been defined now to become more like immunological rather than ischemic. And when you talk about the pathophysiology of preeclampsia now, it is said it's because of an abnormal maternal immune response to the invading trophoblast of the placenta. This will cause a defective placentation. And this is usually driven by primiparity, a change in partner, and ovum donation fertility treatments. And that the pathophysiology is actually, risk factors have changed now compared to what was said earlier. So when there's a defective placentation, it's because of an impaired endovascular invasion of the spiral arteries in the uterus by the trophoblast. This will cause an ischemic change and then a reperfusion injury. And that happens because of the cellular oxidative or the endoplasmic reticulum stress. And when this injury happens and there's a stress pattern there, angiogenic factors are secreted into the maternal circulation, and you'll find abnormal levels of soluble FMS like tyrosine kinase, the SFLT1, and the placental growth factor. And when these two are abnormal, it will lead to an angiogenic imbalance. And when this imbalance happens, there's going to be the diffuse endothelial damage, and the change in the angiogenic factors is going to cause an increase in peripheral resistance. And when the kidneys get involved, there will be proteinuria. And the peripheral resistance, which is increasing, will go on to systemic hypertension. And there will be a change in the cerebral vasculature resistance. And vasospasm happens when the cerebral vasculature leads on to cerebral edema. The patient manifests with seizures with the symptoms of eclampsia. So the abnormal placentation, which can be because of predisposing factors like genetic factors, environmental factors, immunological factors, diet, and obesity, they will cause the abnormal placentation. And this abnormal placentation will cause a hypoperfusion of the placenta. There's ischemia of the placenta. The placenta is going to release factors such as SFLT1, which is going to block the angiogenic factors, vascular endothelial growth factor, and inhibit endoglin, and the TGF also gets induced. So they will have a diffuse endothelial damage, and there will be a decreased VGF and decreased TGF beta. So all this will contribute to resistance and hypertension. So, but there's now one change in the hypothesis. We always thought that preeclampsia is a primary placental disorder, in spite of not having any clear evidence. But now there's an emerging evidence that preeclampsia is not a primary placental disorder. It is actually a secondary placental dysfunction. And that they say it happens because a mother is already having a suboptimal maternal cardiovascular performance. And that will cause a decrease in the uteroplacental circulation. There's a hypoperfusion in the uteroplacental area. And because of the secondary dysfunction, it's going to contribute to the change in the angiogenic imbalance, change in the angiogenic balance, and that will contribute to hypertension. And there are now abundant studies in 2021, which have stated that cardiovascular dysfunction in the mother precedes the development of preeclampsia by almost several weeks or months. And they have given echo reports and testing of the vascular system to say that these changes happen in the mother even before she lands up with preeclampsia. So it's actually, they think now, the placenta is not the villain, it's now the victim. And the hypothesis points towards a primary problem in the maternal cardiovascular system, which is causing the placental dysfunction. And how do you manage severe preeclampsia when it happens? There are not much of changes, but this triad of management has to be done. You give, when there's a patient with severe preeclampsia, the blood pressure of 160 by 110, you will give her antihypertensives to control the blood pressure. Anticonvulsants are a must. Magnesium sulfate is the anticonvulsant of choice and should be given for any severe preeclamptic who comes to you. And if the baby is premature, corticosteroid should be given to improve the development of the baby's lung. And that is the SOGC guidelines as well as the WHO guidelines for management of severe preeclampsia. When you come to chronic hypertension, then you have to give hypertensives to maintain the blood pressure in the range of 110 to 140 by 80 to 85 diastolic. Give her antihypertensives, which can be nifedipine, hydralazine for severe hypertension, labetalol, oxypranolol, methyldopa, prazosin, and hydralazine. That's your choice. Ultrasound for the baby should be done from 26 weeks to identify a growth restriction and has to be done at 2 to 4 weeks interval. Always monitor the blood pressure and the urine protein in a mother who's got a chronic hypertension and induce labor at term, which is well controlled. And that is from the American hypertension journals, which tells us the management of chronic hypertension. And the other change which has happened in the landscape is now there's a thought about the medium complications and the long-term repercussions of this disease and how do you prevent these problems. The importance is given for long-term implications because they are innumerable and sometimes irreparable. So the management has to start once a diagnosis is made, so the future is secured. And when a pregnancy is complicated by preeclampsia, we have to remember 20% of the women in the next 7 years will develop hypertension or microalbuminuria and may go on to have a chronic renal disease. And the same, but when you compare it to the lady who had no complications to a pregnancy, it's only 2% of these women will land up with complications. But when she's complicated by preeclampsia, almost 20% will go on to have problems of hypertension and microalbuminuria in the next 7 years. Similarly, there's a high risk of acute myocardial infarction, stroke, and venous thromboembolism in these women who had a personal history of preeclampsia. So these are the repercussions which have been thought about, and the prevention should start quite early. And there's a thought about the fetal effects of this disease also now. Neonatal complications we know happen because of prematurity, but some studies have already shown a negative impact on the neurocognitive development of these infants when they are evaluated in the first 2 years of life. So do not think that you'll save the baby and the mother. The complications may go on later into the neonatal time also. And the near-death experience of these mothers who develop preeclampsia and eclampsia has been given so much importance because there are so much psychological consequences suffered by the mother because of the disease. There's an emotional impact of this disease that involves anxiety, isolation, difficulties in feeding the baby, depressive disorders later in the life, and impairment of reproductive capacity. And the prolonged stays that these mothers have in intensive care units because of either the women herself or the newborn, and the physical or mental limitations to them may interrupt the natural order of symbiosis. The bonding between the mother and the baby may be damaged because of the near-death experience of mothers suffering from preeclampsia. And what are the preventive strategies which have changed over a period of time? Now we have changed from 75 milligram aspirin to 150 milligram aspirin based on the ASPIR trial. Now metformin has emerged as a target of studies for study of this disease in preeclampsia. And pravastatin, the statins have been thought of as a good option to prevent preeclampsia. Proton pump inhibitors like esomeprazole is also being studied for prevention of this disease. And the ASPIR trial, the combined multi-marker screening and randomized patient treatment with aspirin for evidence-based preeclampsia prevention was designed to test the hypothesis that if there's a high risk for preterm preeclampsia, when you do a screening for these mothers, when you give aspirin at dose of 150 milligram per day, they wanted to know whether the incidence of preterm preeclampsia reduced. And this randomized trial showed that the administration of aspirin resulted in a significantly low incidence of preterm preeclampsia than the ones who had just placebo. So 150 milligram of aspirin in high-risk conditions will definitely prevent the incidence of preterm preeclampsia. And the other drug which has been studied for the prevention now is metformin. They say it reduces secretion of anti-angiogenic factors from the placenta in a dose-dependent manner. And it can also mitigate the endothelial dysfunction and can promote vasodilatation in whole maternal omental blood vessels when it was used. And in mice, when they used it, it was found to have angiogenic properties that can promote vessel growth from the aortic ring. So these are all evidence that metformin can be tried as a preventive modality for the prevention of preeclampsia. And the other drug which has been studied now, pravastatin 20 milligram daily, and there are two big trials which are undergoing actually. The trial in Europe, that was the UDRA CT 2016 to 19, recruited 1,120 participants, but the recruiting is not yet over, and they have not stated the date of publication. The other trial, NCT, which is being 0394451 in United States, has recruited 1,550 participants, and they're still recruiting, and the recruiting period is actually till 2031. And they found out that this drug, the basis for these studies was that this drug is known to have beneficial actions on both the placental and maternal vascular disease. And it was given in vitro. The administration of the drug to the placental tissues or cells upregulates the antioxidant pathways and can actually promote a favorable angiogenic profile by decreasing secretion of SFLT and S-endoglin. So there are a large number of trials which are underway, and these two are the big trials. And when they come into the picture, probably it will give us an idea like we can use one more drug other than aspirin to prevent preeclampsia. And the proton pump inhibitors, lansoprazole, rabeprazole, and esomeprazole, are known to decrease the placental release of SFLT and SNG in vitro. And actually, it happens at lower concentration than the statins. And they're known to reduce placental and vascular pro-inflammatory cytokine production and can mitigate the endothelial dysfunction. They can also facilitate a favorable vascular dynamic as it upregulates phosphorylated nitric oxide synthase in endothelial cells and probably improve the vasodilatation and help in the management of this disease. And what is the change in the prediction of preeclampsia that has happened over the decades? Earlier, it was the pyramid proposal for prenatal care, but now it's a new inverted pyramid proposal for in your prenatal care. Here, all the efforts need to be concentrated in the first trimester to identify this disease so that you have an earlier diagnosis and you can put up therapeutic proposals established even in the subclinical stage of aggravation of this disease. So when the disease is fully established, it's very difficult to manage. So you need to start your investigations in the first trimester, diagnose it early, put up the therapeutic proposals even before the whole disease is manifested so that you manage it even at the subclinical phase. And the next change which has happened is when they've differentiated this disease depending on the moment of manifestation. If it happens before 34 weeks of pregnancy, it is now called as early onset preeclampsia. And when it happens after 34 weeks, it becomes a late onset preeclampsia. And it's totally different. The placental damages and the phenotypes are quite different between the two types of the disease. In early onset, you will have a lower placental volume. It is because the vascular lesions predominate in the early onset preeclampsia. It is more associated with placental insufficiency and the growth restriction of the baby. But when it happens after 34 weeks, actually you will see signs of chronic inflammatory response. It's not the vascular lesions you see, and it will be associated with the milder clinical conditions, and the placenta will be of normal volume. It will not be low as in an early preeclampsia. And that's because we have to differentiate between these two types of preeclampsia because there are different damages happening to the placenta and the phenotypes are quite different. And what is the difference in the risk factors between early onset and late onset? You will see that early onset preeclampsia happens more in multigravidas. And when they have chronic hypertension and a past history of preeclampsia, you have to be ready for an early onset preeclampsia in this pregnancy. And this is based on an 18-year observational cohort study. And late onset preeclampsia is common in primipara, a lady who's above age 35, and when she's a higher BMI, a BMI more than 35 will contribute to a higher risk of late onset preeclampsia. But there's one important fact they found out. Diabetes was not an independent risk factor, neither for early onset preeclampsia or late onset preeclampsia. That was a surprising finding. And what about the age and onset of preeclampsia? Rising maternal ages are actually associated with both early onset and late onset, while increments of BMI, that is obesity, is more associated with late onset preeclampsia. And what about BMI and late onset preeclampsia? They are specifically associated with late onset. And this may explain the discrepancy we are seeing in different countries. In high-income countries, more of preeclampsia or late onset, and that is basically probably because of the BMI and diabetes, which is there in high-income countries compared to medium to low-income countries where it happens more in primiparas, and it happens 60 to 70% will be the late onset is only 60 to 70%, but in 90% of preeclamptic cases in high-income countries will be late onset preeclampsia. And when you talk about the weight of the mother, the risk of preeclampsia doubles with each 5 to 7 kilogram per meter squared increase in the pre-pregnancy weight. A lady who enters pregnancy with a high BMI is going to have a higher risk of preeclampsia. And the mechanisms have not been totally explored. They only partially explored, and they say maybe because of an increased cytokine-mediated inflammation and an oxidative stress, probably an increased shear stress, a higher chance of dyslipidemia, and then there's an increased sympathetic activity, which has been proposed as possible pathways. The problem of maternal corpulence is actually interesting in preeclampsia because it tells a changing landscape of this disease. In the earlier decades, in 1950, 31, 52, Davis, and all these textbooks never mentioned that overweight and obesity is a risk factor for preeclampsia, but now it's almost like a tsunami. Those years, probably obesity was not an enormous public health problem. Now it's an epidemic, and it started around the year of 1975. And the interest in the effect of obesity as a risk factor of preeclampsia has been raised in the beginning of 1990s, and the beginning of the 21st century is almost like a tsunami. So maternal corpulence and increasing BMI is increasing the higher risk of preeclampsia in our mothers now. There was a study which was done in 2014, and they took 2,637 women in this analysis. And they found out when a patient is overweight or obese, this was the most important risk factor for both preeclampsia and severe preeclampsia, with the attributable risk percentage of almost like 65% for both overweight and obese women landing up with a complication of preeclampsia and severe preeclampsia. It's so important now. What about ART treatment, which is contributing to an increase in preeclampsia? According to the study in 2019, it has caused an increase of almost 1.71-fold in preeclampsia. And the reasons why assisted reproductive technologies are contributing to preeclampsia is there is an abnormal placentation in ART pregnancies. In some ART procedures, the blood flow is compromised because of the procedures and the drugs. And when it's diminished, it's going to cause more of obstetric complications. And it can also happen because of a placental insufficiency, because of an altered hormonal endometrium, because you give the load to the patients with estrogen and progesterone, and probably that causes an insufficient placenta. And it has also been argued that assisted reproductive technology may cause epigenetic effects in the placenta and the fetus, and that may contribute to an increase in risk of preeclampsia. What about donor gametes, which are contributing to preeclampsia? When the mother conceives through donor oocytes, there's a higher risk of preeclampsia. Here, the placenta may not be the villain. The role of the maternal immune reactivity towards a foreign gamete, that is a foreign and a foreign fetal antigen, may play a role in the higher incidence in donor gestations. And remember, there's almost a 25% of preeclampsia in donor gamete pregnancies, and that's why donor gametes being used for pregnancies in older mothers have to be taken with a pinch of salt. What about frozen cycles? Artificial FET cycles have got an increased risk of preeclampsia in comparison with natural and stimulated cycles. In frozen cycles, you do not have the corpus luteum, and that may contribute to the observed increased risk of preeclampsia. The corpus luteum is known to secrete vasoactive hormones like relaxin, which are not replaced in artificial cycles where you give just estrogen and progesterone. This may compromise a maternal cardiovascular adaptation to the pregnancy, resulting in an increased risk of preeclampsia. What about recurrent miscarriages and the association with ART? The pregnancies from ART are associated with preeclampsia through oxidative stress. And when you see the patient with recurrent miscarriages, there is also a similar pathology there, more of oxidative stress that's contributing to miscarriages. So when you have an infertility treatment for a patient who's got recurrent spontaneous miscarriages, there's a tremendous increase in the risk of preeclampsia in comparison to those without treatment. That was a study in 2015. So in recurrent preeclampsia, the rates have increased over the past 2 decades. It's not decreased at all, in spite of so much of diagnosis, management, and all that. And this is maybe because of the increase in diabetes mellitus, obesity, and chronic hypertension in our mothers. And that's why the rate of recurrent preeclampsia has increased so much. And when the patient has had a previous preterm delivery because of preeclampsia, or she has undergone a cesarean delivery because of preeclampsia, there's a higher risk of recurrent preeclampsia. So any complication of the previous pregnancy, please remember, there's a higher risk of recurrent preeclampsia in this pregnancy also. So what are the reflections on advances in preeclampsia research over 2 decades? And this has been brought about the 11th workshop in immunology of preeclampsia in Reunion 2018, which celebrated its 20th year, the 20th candle. all the members of the workshop, they reflected on the main tracks during which has happened in 2 decades of research on this disease. And the first reflection they had was the advance in immunology of reproduction, the field of preeclampsia, which was poorly developed 2 decades ago. So immunology has developed, and that's why the understanding of the disease has increased. The second reflection which this group had was, why does preeclampsia exist in humans? Because in an evolutionary point of view, there is no established natural animal model in almost like 4,000 other mammal species which do not have this disease at all. The third reflection which this group had was the biological plausibility of preeclampsia disease of first pregnancies at a level of a couple. That is, remember that primary paternity is the one which corresponds more with preeclampsia more than primary gravida. And that's why that paternal-maternal conflict, the immunology part of it, is not being fully understood still. But there's an apparent conundrum because the human species should have disappeared because more than 40 to 50% of this diseases, hypertensive disorders in pregnancy, happens in couples who conceive in the first 4 months of sexual cohabitation. So actually this disease should have died and the human species should also have disappeared. The final reflections of this group was the main difference between early onset and late onset preeclampsia. The early onset is because of immunological problem and the late onset is because of maternal vascular predisposition, which is not good for the pregnancy. And the debate of why high-income countries report almost 90% of the preeclampsia being late onset, while other countries describe epidemiologically very high incidence of early onset preeclampsia. This debate is still going on. And the final thought of this group was the pathophysiology of this reversible systemic maternal vascular inflammation, which disappears after delivery of the baby. So when you talk about early onset and late onset preeclampsia, the concept which has been accepted now is there's a failure of trophoblastic invasion and the adaptation of the uterine spiral arteries, which leads to relative placental ischemia in early onset. Whereas in late onset, it's because the increased maternal susceptibility to the vascular and the metabolic stress of pregnancy is a reason for late onset, or maybe because an advance in placental senescence, which will release damaging vasoactive factors late in pregnancy, causing late onset preeclampsia. So I want to conclude this talk, which can never be concluded because the disease, the understanding of this disease is still not fully known to everybody, but the landscape is totally changed. The pathophysiology has been defined, but we are still not there. Proteinuria is not an essential condition to characterize preeclampsia now. There's a change in trend. The developed countries have more of late onset preeclampsia. The developing countries have more of early onset preeclampsia. The risk profile has totally changed. The mothers being older, higher corpulence, increase in BMI, and use of assisted reproductive technology has increased the incidence of this disease. And there's now a proposed theory of change in placenta being the victim rather than the villain. And the long-term repercussions of the disease are being taken quite seriously now. The fetal effects and the psychological effects of the mother are being highlighted. I'd like to thank AMOGS, Dr. Pardeshi sir, Dr. Suchitra ma'am, Dr. Bharati, and a special thanks to Dr. Pratik Tambe for the opportunity. Thank you so much.
Thank you, Dr. Charmila, for giving us absolutely changed landscape so far as hypertensive disorders are concerned. We always thought that abnormal placentation was at fault, but then we realized that it's an immunological factor which is responsible for abnormal placentation, which in turn leads to hypertensive disorders. Proteinuria, we always thought was very important so far as preeclampsia was concerned, but now the concept has changed that even if you have hypertension without proteinuria, what we need to look after is multiple organ dysfunction, which needs to be more or less looked after rather than only going behind the proteinuria part of it. And secondary placental dysfunction was mainly after the cardiovascular dysfunction of the female. So we need to look after the cardiovascular dysfunction just to find out that maybe the patient could have a preeclampsia later on during the course of the pregnancy. So far as management is concerned, it's more or less remained the same. More stress on hypertensive disorders than on magnesium sulfate so far as preventive eclampsia, and of course steroids. There's something what she spoke about was early preeclampsia and early onset and late onset preeclampsia. In developing countries, you find early onset preeclampsia as compared to the one in the developed countries, you find late onset preeclampsia. And so far as prophylaxis is concerned, we always harp on the aspirin. Aspirin remains as the forefront, but we do have now other molecules which are being studied like metformin, like statins, And third more, I think proton pump inhibitors. So maybe a few years from now, we could have one of these drugs also helping us so far as prevention of preeclampsia is concerned. And last thing, more stress has to be put on the first trimester to predict the possibility of preeclampsia. And in case you find that the patient have some predictability so far as preeclampsia is concerned, start up with the prophylactic treatment so that she doesn't develop preeclampsia or PIH later in the third trimester. Okay. So thank you so much, Charmila, for giving us a different landscape so far as hypertensive disorders or preeclampsia is concerned.
Thank you, Dr. Charmila and Dr. Suchitra, madam. Pardeshi sir, any comments before we move on to the next talk? We'll take the questions at the end of the session.
It was a really excellent talk by Charmila, as usual. She is all-rounder and she has given all insights of the hypertensive disorders. Thank you, Dr. Charmila.
Thank you, sir. Thank you so much.
Thank you, Pardeshi sir. It's my privilege to introduce the next chairperson for today, Dr. Bharti Maheshwari. Madam is the professor and head at the Muzaffarnagar Medical College. She's been chairperson for the POXI MTP committee in the past, as I've already said. She's a governing council member of ICOG, just like I am, and she's been secretary of UPCOG. In that capacity, she has organized so many conferences and spread the word regarding preventing maternal mortality and improving women's health. She's done commendable work in the MTP committee, of course. She's published papers and review articles in several index journals. She's also been the person who delivered the Kamini Rao UAFOXI oration from the North Zone. Welcome, Dr. Bharti Maheshwari, madam. The stage is all yours. I request you to introduce our distinguished speaker, Dr. Suchitra.
Thank you, Dr. Pratik Tambe. First of all, I would like to thank and congratulate you as the AMOGS Endocrinology Committee on this webinar. Thank you for inviting me. And definitely, it's a very important topic, preeclampsia and eclampsia, hypertensive disorder of pregnancy. They always remain challenges for all of us. For last 20 years, many things are, researches are done, lots of work has been done for pathophysiology, for the management, prediction, diagnosis, but still we are doing. So my greetings and namaskar to Dr. Pandit sir, AMOGS President, Dr. Sujata, and of course, speaker, Dr. Charmila. She has really, I was mesmerized by her talk, that how she has, then I was just flowing in her talks and her PPTs. That was really a good perspective she has kept preeclampsia. And now it's my honor to introduce the next speaker, none other than Dr. Suchitra Pandit. She is the past president of POXI. We all know it. And not only this, that as a past president, we all know her as a very good, humble, and very sweet human being, always very encouraging for her juniors. And we all know that she is President ISOPAB also 2018 to 20, President of Gestosis, has done a very good job, and we have attended her lots of conferences organized by her in 2015 to 18, and POXI and ICOG President, of course, 14-15, POXI representative of AOFOG 15 to 70s, and she has chaired the CEFOG Medical Education Committee. She is the President MOGS, Professor and Unit Chief as medical colleges in the Mumbai, and have done lots of publications, books, and lots of adolescent empower projects and other things. So now I'm not coming in between you and Dr. Suchitra Pandit. Dr. Suchitra Pandit is going to deliver a very important part of pre-hypertensive disorder of pregnancy, that is eclampsia, how to prevent morbidity and mortality. So, madam, we are just curious to hear you. Dr. Suchitra Pandit, madam.
Thank you so much, Dr. Bharti. Thanks to Pratik for giving me this opportunity, and hello to Rajendra Pardesi and Dr. Sujata, President and Secretary of AMOGS. Can I just share screen?
Yes, ma'am. Please go ahead.
Yeah. Yeah. Is it there?
Yes.
Is it there?
Yes, ma'am. Please go full screen.
Yeah.
This is actually full screen only. Okay, I'll just try again once more.
Mm-hmm.
If you can hit F5 on the keyboard.
Yeah. Is it okay now?
Perfect.
Yeah.
Perfect. Yes.
Okay. So, after that wonderful lecture by Charmila in the changing landscape, We will move on to eclampsia. Of course, I would like to mention before I start off that through the Gestosis India Association, we have the Gestosis score, and that is something, in the low to middle income countries, we can use the Gestosis score to predict. If you have that score of 3 or 4, then obviously you start off with low dose aspirin. And then, of course, when a patient has access to ultrasound, you do the first trimester scan along with the dual marker and the Ayyavoo screen, you probably get a better predictability. But where this is not possible, the Gestosis score is a great tool, and it has been validated by Dr. Meeta from Jammu. It is already published in the Jogi. And please start using the Gestosis score. It is available on the Android phone. You have to download it from the Play Store and use that. It's useful for the general public. My topic for today is eclampsia, preventing maternal morbidity and mortality. And as we all know that eclampsia is considered as a complication of severe preeclampsia, and it is commonly defined as a new onset of grand mal seizures, as well as unexplained coma, which can occur during pregnancy or the postpartum period. And sometimes there may be no signs and symptoms of preeclampsia, but most of the time there will be a form of preeclampsia. It occurs during or after the 20th week of gestation or in the postpartum period. And remember, 10% of all pregnancies are complicated by hypertension, and preeclampsia and eclampsia account for about half of these cases globally. And these conditions have been recognized and described for years, despite a complete lack of understanding. More and more is known about it over the years. Way back in 5th century, Hippocrates had noted that headaches and convulsions, along with drowsiness, were ominous signs which were associated with pregnancy. And in 1619, Verandis had coined the term eclampsia so that people should start using this term. Now, the definition of preeclampsia, as Charmila has very rightly pointed out, no longer includes proteinuria, because you see the advanced disease even before the proteinuria. So I won't go back into the definition as she's already done that. But eclampsia is defined as a new onset of generalized tonic-clonic seizures in a woman with preeclampsia, may or may not be, which typically lasts for 60 to 90 seconds in duration. And eclamptic seizures can occur antepartum, 20 weeks after gestation, intrapartum, or even postpartum. And seizures before 20 weeks are rare, but they have been documented in women with gestational trophoblastic disease. So exact etiology is still unclear, but probably the two mechanisms which are being proposed, adding to the newer ones which are coming up, as it is abnormal placentation, as now Charmila has pointed out that the cardiovascular problems pre-existing in these women can also cause a complication. But however, we just need to know that there is an inadequate invasion of the cytotrophoblast, which lead to poor remodeling of spiral arteries. This reduces the blood supply to the placenta, and abnormal blood supply leads to the increased uterine artery resistance, vasoconstriction, and finally ischemia and oxidative stress. And probably this is the basis of all the predictors, where the free radicals, the cytokines, the VEGF, and all the pro-inflammatory proteins and angiogenic proteins are looked at. And on the basis of the blood test, you're able to predict women who are going to have that severe preeclampsia, and you can prevent that so that you don't go on to eclampsia. The second proposed mechanism is that elevated blood pressure from preeclampsia causes dysfunction of the autoregulation of the cerebral vasculature. This causes a hypoperfusion, endothelial damage, or edema. So whatever be the mechanism, today when we see eclampsia, we know that it can occur more commonly antepartum, and usually most of the cases will get it after 28 weeks. And the post-ictal state, which is often present after seizure activity, people can have warning symptoms such as headaches, visual changes, abdominal pain, and increased BP before the onset of the seizure activity. And there's a whole lot of differential diagnosis which comes on. Of course, as clinicians and obstetricians, we know what eclampsia is, and sometimes we are able to make out that this is not probably due to a brain trauma or a ruptured aneurysm. However, we need to keep in mind that chronic renal disease, chronic hypertension, primary seizure disorders, gallbladder disease, the APLA syndromes, the hemolytic uremic syndrome, pancreatic disease, ITPs, there are toxins and there are, situations like intracranial hemorrhage, brain tumors and stroke, which can mimic convulsions in pregnancy, and therefore we have to watch out. So I'll begin with just a case and then go on to what is the management of eclampsia. This is a 19-year-old pramigravida at 36 weeks of gestation. She's been to hospital only thrice for antenatal checkup, and finally she moves over to a fourth hospital because that's her mother's place. A common thing where girls go in their mother's place for delivery. And she's been brought in an altered state of consciousness with a history of one episode of convulsions at home. In the labor ward, her BP is 220 by 140, and she has 3 pluses of proteinuria. She is not in labor. So what are the principles of care? Obviously, acute management is left lateral position, airway, so what we call as a mouth gag earlier, and oxygen, and seizure prophylaxis with magnesium sulfate. Fluid monitoring and restrictions, obviously seek IV, cannulation, and 2 arms is always better. Start off an antihypertensive therapy and simultaneously do an investigation and then consider a delivery. So this is the chart we had developed at the HDP consensus meeting. And we had thought that this would be given to all the labor wards, and the colored printouts in the labor ward always are very striking. So you shout for help. Please take a 16 or an 18 cannula, not a 22 and a 24, because you have to take out a lot of blood and you have to give them fluids as well as magnesium sulfate. Place the woman on a left side to reduce the risk of aspiration, secretions, vomitus, and then assess the breathing, that is the ABC, and check airway. Do you really need an intubation or is she stable enough? So rapidly evaluate the vital signs, and if she is breathing well and if her SpO2 is normal, you can still start off with a 4 to 6 liters of oxygen and examine the neck for rigidity. Simultaneously, one of your assistants can take the history from the relatives and find out exactly how many convulsions have occurred and have they done anything at home, have they taken her to any other place, and if she has already convulsed in front of you, clean her mouth and throat, because there'll be a lot of secretion and there's a risk of aspiration. And when you start off with the max self, you've already got that IV line. Collect blood for her blood group, CBC, platelets, sugar, LFT, RFT, and a coagulation profile. Simultaneously, get your assistant or your sisters to get this max self ready and gently catheterize the patient. Sometimes it makes sense to put in the first lot of magnesium sulfate, the loading dose, before catheterizing her, because you don't want to have a rebut convulsion immediately. So the dose I'm not going to mention right now because we're going to go through this in detail. Standard is a Pritchard regime, which IV loading dose and followed by the intramuscular 10 grams, 5 grams on each buttock, or in many of the corporate hospitals and many of the teaching hospitals today, they started giving the IV loading dose 4 grams at 1 gram per minute. And this is followed by an infusion 1 gram per hour. And then we are looking also at the antihypertensive therapy, because most of these times in this particular case, BP is high. So we will have to consider giving her antihypertensive therapy. So it may be a choice of labetalol, nifedipine, hydralazine. We'll go through that in detail. But as you're monitoring the patients, do not forget the vitals, the pulse, blood pressure, respiration rate, patellar reflexes, and a urinary output. So maintain a strict fluid balance chart, because people tend to over-infuse these patients. So make sure that we don't have a fluid overload. Provide a maintenance note. So your charts should be in place to know exactly when you've given the anticonvulsant, that is the Maxelf, and the antihypertensive drugs, and auscultate lung bases for RALs, because that is an indication of pulmonary edema, and then plan the delivery. So the investigations I've already mentioned, all these will be done. I'd like to add on LDH to this. It was not mentioned earlier times, but now we've realized that rise of LDH and early rise of LDH is an indication of the HELP syndrome. And when a massive rise is there, you know that the HELP syndrome is on, you're going to start off soon. So then you have to plan your delivery and probably expedite delivery in those situations. And we have added on a serum electrolyte as well as a PCR to that. Now, the collaborative eclampsia trial has clearly said that Maxelf is the drug of choice. They had studied Maxelf versus diazepam, Maxelf versus phenytoin. So 52% risk of reduction of the recurrent convulsions, and 7% lower risk of reduction of recurrent convulsions as compared to phenytoin. So world over, in India, 87, we had started using magnesium sulfate, but it required the collaborative eclampsia trial to tell everybody that Maxelf is the gold standard. And how does it act? It causes a cerebral vasodilatation, blocks the NMDA receptors in the brain, thereby reducing the calcium influx, alters the neuromuscular transmission, and protects against neuronal damage. Very, very important effect of magnesium sulfate. And it does cause arteriolar vasodilatation. It does help in reducing blood pressure, but it is not an antihypertensive drug. And of course, when you're using it along with the calcium channel blocker, we are okay. Earlier times, people used to worry about using Maxelf and nifedipine together, but no, today we are not worried about that. You can also use nifedipine. Only thing we suggest is don't use sublingual because it causes a precipitous fall in the blood pressure. So you have to use it orally. So in a patient who is probably not able to take anything oral, we probably have to just consider giving Maxelf and other antihypertensives. So how do you prepare the drug? Today, we advise everybody to keep a 50% weight by volume, much more easier to calculate for the staff nurses. 4 ampules of 50% weight by volume, and each ampule contains 2 ml. So that is 8 ml, that is 4 grams. 4 grams diluted with 12 ml in normal saline, given slowly because you don't want to have a respiratory arrest. Look at the clock, 15 to 20 minutes. And once you've given it, that is your loading dose. And then you decide whether you want to go in for a continuous Suspans regime or you want to go in for the Pritchard's regime. So if you're giving the Pritchard regime, a very important point is the betadine solution should be used to clean the skin over the buttocks, and it should be a deep intramuscular injection. There is a lot to be given. 5 grams, 10 ml is a lot of injection to be given. So it has to be deep intramuscular on both the buttocks. And it is advisable to use 1 ml of 1% xylocaine because there's a lot of pain when you're giving it. And sometimes giving that intramuscular shot can also evoke a convulsion. So therefore, the IV loading dose is very, very important. And remember, your eclampsia trolleys should be stocked with the antidote, that is calcium gluconate, because that 10 ml of 10% solution over 10 minutes can counteract the overdose of Maxelf. And of course, an ECG monitor should be available, maintaining airways and oxygen. So this is what our eclampsia kit concerns. And in busy maternities, it is duty of the main staff nurse as well as the chief registrar to ensure that adequate amount of Maxelf syringes, distilled water, and the cardiac capsules are there. And of course, the Foley's catheter, which is very important. So this is a list. The scissors, sometimes you have to go running for scissors and tapes. Keep everything ready. 3 ways, the collection bottles and the mouth gag, all should be in the eclampsia trolley. And today we want to tell you about something very nice, which has now come up. The Blisson have come on with this IV Maxelf. This is a real savior because it is all ready. Nobody has to calculate. Nobody has to break ampules. Just open up this particular product, IV Mag. And I thought this was very, very useful, particularly in the emergency rooms. Just get it ready. The advantage is there are no manual errors. It's a time saver in critical situations. No dumping of sodium, and it's convenient for the paramedical staff. And of course, we know all the roles of Maxelf. I'm going to talk to you about that a little later. But also Maxelf serves in, if you're giving a Suspans regime, you have a ready-made dose, continuous infusion for 1 gram per hour. So you have to have your, the IV infusion pumps so that this is used. So this is what exactly it looks like. So whether you're using a Pritchard's regime or whether you're using a Suspans regime, in both cases, you need a maintenance therapy. So in the Pritchard's regime, after the loading doses are over, you have to give 5 grams every 4 hourly on alternate buttocks for 24 hours after the last convulsion of the delivery. And in the Suspans regime, the infusion maintenance is 1 gram per hour and again continues for 24 hours. So the principles are the same, only the modes of giving are different. The advantage of the Suspans is it is less painful, and in places where there is facility of monitoring, it's much more easier. But Pritchard's is what we used to give when we were working at Sion Hospital, and many a times it still continues in the medical colleges. So patellar tendon reflexes, I've always said that if you can't elicit these, sometimes legs are very edematous and it is difficult to lift up this. You can look at the biceps, the supinator, or the triceps reflexes. You can look at the ankle clonus, because if you're not able to elicit this, it means that the patient should not be immediate. You give the loading dose, but after that, you shouldn't be continuing till you've elicited these reflexes. Respiratory rate should be more than 16 per minute, and urine output should be 30 ml per hour. And always check, is the catheter properly inside? Sometimes you may get a zero output, but that may be because the catheter is blocked. And of course, it may be because the patient is in hypertension. As it is in eclampsia and pre-eclampsia, the third space tends to get compromised. So be very, very careful about that. Now, if you've given your Maxelf and the convulsions recur after 15 minutes, you can repeat 2 grams of 50% again over 5 minutes. Common side effects is flushing, nausea, vomiting, muscle weakness. But remember, if the patient is getting drowsiness, confusion, make sure that you have not given it very fast. And there can be drug interactions with general anesthesia and diazepam. So be very careful. And this is the chart which everywhere is being used. The pulse, BP, respiratory rate, urine output, the fetal heart, magnesium sulfate dose. And of course, once you've given the Maxelf, check, do an internal examination to check what the Bishop score is and what is the presentation of the patient. Now, when you want to maintain a level of 4 to 7 milliequivalents, that is the right dose, in this situation, it is perfect. But if you find that the patellar reflex is disappearing, mind you, a pre-existing patellar reflex now not being elicited is a first sign of toxicity, which means your level is crossing 8. If the uterus gets totally relaxed, it is 8 to 10. And if there is a respiratory depression seen by the falling down of the respiratory rate, it means your levels are going higher. So please stop Maxelf at that time. So do you really need to do a serum magnesium level? Well, it is done in the Western countries, but in our setups, it is not always possible. So, and they have not been shown to be superior to clinical monitoring, but your clinical monitoring, no shortcuts at all. And even when you're giving Maxelf for neuroprotection in preterm labor, you still have to elicit the patellar reflexes. So this is what I've already mentioned to you. If there are absent patellar reflexes, and the respiratory rate is normal, just withhold the Maxelf till the reflexes return and restart at lower doses once the reflexes return. If the urine output is less than 100 ml in 4 hours, and if there are no other signs of toxicity, reduce the dose to half, but after checking that the catheter is intact and is in situ. If there is a respiratory depression, which I've already mentioned, immediately stop the Maxelf, start the oxygen, maintain the airway, and give the antidote, the rule of 10, which I've already mentioned. And friends, I've already said this time and ago, those who are working in busy maternities, residents should be well trained for doing an intubation and ventilation, because in case of a respiratory arrest, that is what will save the patient. You stop the Maxelf, do give the IV gluconate, and continue to ventilate the patient till the normal spontaneous respiratory respiration is established. 13% of women will have recurrent seizures despite giving the proper Maxelf. As I've already talked about the 2 grams of IV which can be given. But sometimes you have to think and wonder, if the patient is not responding, could there be some other cause? At SIN, we had 3 patients who had not responded. One of them had cerebral malaria. The other one had a space-occupying lesion because of a tuberculosis, and the third had cysticercosis in the brain, and they were not responding. So those situations, we've already initiated a physician's advice, and they have started off with phenytoin. But in these patients, supposing they're not because of the HDP causes, that is the hypertensive disorders, if you've given Maxelf, there is no harm done at all, but then they switch over to phenytoin or diazepam, and benzodiazepine, barbiturates are used as, secondary line where the patient is unresponsive. And of course, in status eclampticus, I've seen only 2 patients in my entire career where they just didn't respond, and these patients had to be intubated and we delivered them. Levetiracetam and valproic acid are other alternatives, but they are more, situations where the patient has had a coexisting myasthenia gravis. So in those cases, you have to be very, very careful when you are giving magnesium or phenytoin, because that can cause a myasthenia crisis. So what is the specialist advice over here? If the patient is having recurrent seizures, yes, please take a physician's opinion and evaluate if the patient is stabilized. After giving whatever drug you're giving, evaluate neurological imaging, because there could be something else sitting in there. And you shouldn't be just going up the wrong ladder, and therefore take the physician, the expert specialist input. If there is a blurring of vision, there could be a retinal artery occlusion, or it could be because of eclamptic convulsions. And we'd seen patients where they've lost their vision completely because of the retinal detachment. But fortunately for the patient, it came back once the blood pressure came down. And magnesium sulfate has a neuroprotective effect, but it is in the newborns. And here again, I'd like to say that we must now have started off the antihypertensive therapy, because you want to prevent stroke and the cerebrovascular accidents. And of course, the antihypertensives are there in severe preeclampsia when you're considering prolonging the pregnancy, or steroids, or for giving and sending the patient for in utero transfers. But in cases of eclampsia, you must consider delivery, because antihypertensive therapies do not change the pathophysiology, they just buy a little time. And what should be our aim? We shouldn't be panicking and trying to get the BP down very fast. Our goal is to get a gradual control, and rapid reduction may cause a severe organ perfusion. Remember, we have a baby sitting in there. So you want to be very, very careful. You don't want an infarct, or you don't want ischemic changes in the mother also. So reduce the diastolic pressure gradually over a period of time. And you can, once the patient is stabilized, you can take oral medications. And patients may have pressure-induced natriuresis, so consider volume repletion to prevent sudden precipitous drops. So in cases of antihypertensive crisis, we have labetalol, nifedipine, and nicardipine, which has entered the armamentarium now. Labetalol, there are various regimes, but the one which is followed commonly, 10 to 20 milligrams IV, and then double the dose or repeat 20 to 80 milligrams every half an hour till a maximum of 300 milligrams. And the infusion rate should be 1 to 2 milligrams per hour. But remember, please check the pulse rate, because if it is more than 100, only then can you give labetalol. If the pulse is less than 100, then please do not give labetalol. Give nifedipine 10 to 30 milligrams, and you can repeat in 45 minutes if required. The other concerns in labetalol are if there is asthma, diabetes, cardiac failure, then again labetalol cannot be used. But nifedipine has got a very nice relative in its family, nicardipine, which is initially used by the cardiologist. Initial infusion rate is 5 milligrams per hour every 5 minutes to a maximum of 30 milligrams per hour till the desired BP is achieved. And the advantage of this is it is available as an IV drug. It is 100 times more water soluble than nifedipine, so easily given IV, and it is titrable. And remember the principles again: lower the BP promptly but slowly. And remember, all these are category C drugs, but then you have to justify the benefits versus the risks. So nicardipine I've already mentioned to you about. The only contraindication is aortic stenosis, unstable angina, or a compensatory hypertension. And if there's a liver or a renal impairment, be very, very cautious. And hydralazine, this is the drug which is available only in the ICU setups. It's not available in our labor wards. It causes a direct relaxation of the vascular smooth muscle and causes a sudden drop if it is not carefully given. And therefore, if you're giving it, it has to be done with absolute cautious monitoring. And if you give it very fast, if the BP suddenly drops, the patient can have a transient hypertension, tachycardia, and a severe headache. So you give this drug only if you want to buy 10 minutes, 15 minutes, 20 minutes till the anesthetist arrives and you've decided to do a section. NTG is another drug which is now being used for hypertensive emergencies in patients with eclampsia and acute pulmonary edema. This decreases the preload by venous dilatation, and the dose is 0.25 to 5 micrograms by infusion, and gradual increase This again causes a severe headache and tachycardia, and you need to have an ECG monitoring. Safdarjung Hospital and AIIMS use NTG even in the labor wards because their residents are trained for the ECG monitoring. But once the BP settles down, you can switch over to the standard preparations. Methyl dopa is no longer available. So now you have to think of delivery. What factors will make you deliver this woman urgently? And if you decide to wait for 48 hours, how would you monitor her fetal and maternal well-being? And if the BP settles to 140/90, would you wait or would you deliver her? The most important thing is if she's severe preeclampsia, you can buy a little time if you are considering in utero transfer. But if she's already convulsed, please consider delivery. Even if she's 32 weeks, you can buy time to give her steroids. You can buy time to give shift her to the in utero, to the tertiary care center. But remember, you have to consider delivery. So you decide about the need and the urgency to deliver, assess the patient's general condition, and check the gestation, presentation, and position, do a vaginal examination for the Bishop score. And most of the times, patients who have convulsed, they would probably be in labor and they would already be, good Bishop score. So all that you have to do is just accelerate the labor, break the waters, check the meconium, and start off with the Pitocin if the patient is well settled. But if there is a preterm severe eclampsia, the patient is maybe 30 weeks or 31 weeks, usually in these situations, the Bishop score will be very poor, and most of the times the presentation will be either breech or oblique. So in this situation, you have to consider cesarean section, but talk to the relatives because the patient may not always be able to speak at such times. Talk to the relatives. So here you have to have a good NICU, skillful delivery backed with experience, because here the lower segment is not very well formed at all. But there's no rush. Stabilize the patient, give her Maxel, get her BP down, and only then consider delivery. However, if the patient is preterm and if she's already in labor, say 4 or 5 centimeters, and the fetus is in cephalic position, you can try a vaginal delivery. But in the case of a breech, then it is not exactly a great option to deliver a preterm breech, particularly if it is 31, 32 weeks, when the weight is more than 1.2, and NICUs can salvage these particular babies. Now, in eclamptic patients, if the patient is already in labor, in the process of labor, we've had such patients at Sion where the patient is actually convulsing and she's in second stage. Please give her the loading dose of Maxel. Start off with the Maxel and then, allow her to deliver. But remember, she may convulse again. Therefore, giving that Maxel is very, very, very essential. Now, how do you optimize neonatal outcomes in preterm deliveries? If the woman has got a severe preeclampsia, in these situations, you can give her Maxel for neuroprotection, you can give steroids, and you can consider transfer to a center with a better NICU. And obviously, betamethasone is a good salt, but there's a shortage. And in those cases, you can give Dexa, 12 milligrams, 24 hours, or 12 milligrams every 12 hourly. Optimize the time because you want to get the best possible outcome. Magnesium sulfate gives a good neuroprotection between 26 to 32 weeks from whatever evidences have been available. And at Surya NICU, which is one of the biggest NICUs, we regularly give this when we have patients coming in at a preterm gestation. And of course, the MAGPIE trial has mentioned about prevention of convulsions by giving magnesium sulfate. And therefore, we do consider that. Anesthesia choice, always regional is better, unless the patient is convulsing or is a status eclampticus where you cannot give a spinal. Otherwise, give a regional because GA is not exactly easy, difficult intubation. You've already given Maxel, there may be drug interaction. So skillful, experienced team of anesthetists should be available. And obviously, regional is contraindicated if the platelet counts are very, very low, which means the patient is in DIC already. Now, once the patient is delivered, your job is not over. You've handed the baby over to the neonatologist, but please keep this patient in the HDU. If you don't have an HDU, put her in the ICU setups or keep an HDU, wherever the maternities it's possible. Please establish an HDU according to the government guidelines. You have to look after the BP because it may not come down immediately. It may take 4 to 7 days for it to come down. Sometimes the BP drops down after delivery, but rises again after 4 to 7 days. Make sure you've evaluated the cardiac status. As Charmila very rightly pointed out, there could be some pre-existing cardiac problems, and these are the patients should be monitored. There should be a cardiac consultation. And in fact, we also advise a 12-lead ECG and a 2D echo. Find out the cause of the BP. It could be autoimmune causes, particularly if it is preterm eclampsia or preeclampsia, but rule out, sometimes it could be a kidney problem. So make sure you've done the renal Dopplers, not immediately. Wait for, till the patient's BP settles down. And if there is a renal problems, please take a nephrology opinion. Sometimes the patient can be discharged if she's settled down after 3 to 4 days, but call her back for monitoring or advise domiciliary monitoring. Many of the patients today buy the BP apparatus and do it, or if they're in a smaller place, the ASHA workers can do it, or if they're in a medical college setup, they can be called back and soon consult not just the patient, but also the relatives for lifestyle changes and contraception. Many a time these patients conceive within 6 to 8 months, and it is risky for them as well as their life. So time and again, keep talking about contraception and preconceptual counseling if they want a child in future. So coming to the last slides, the complications of eclampsia: respiratory failure, renal failure, liver failure, and the posterior reversible encephalopathy. So prevention of convulsions is very important. Most of the cases of breast will resolve in a couple of weeks, but they require an ICU setups because they've got a lot of angiogenic edema. Particularly with MRI and CT, you can find out the parieto-occipital lobes will have that big hyperintensity. And the main treatment is discontinue offending medications, lower the blood pressure with labetalol, nicardipine, or nifedipine, give them Maxulf. If not Maxulf, if they have got some other cause, phenytoin or benzodiazepines, correct the coagulopathy. The vasogenic cerebral edema will gradually settle down. Quite a few times these patients are also given mannitol to reduce the cerebral edema, and if required, a temporary renal replacement therapy, a hemo or a peritoneal dialysis is given. But remember, these patients of breast respond beautifully to their treatment, and within 4 to 5 days, they can be brought out of the ICU. So don't forget, don't just give them up as given cases. So the last slide, prevent preeclampsia. Today we have predictors, and Charmila has given such a beautiful, change of plans. Think of all those plans, but detailed history, weight, BP, gestosis score. If the gestosis score is 3 or more, start aspirin and calcium 1000 to 1500 milligrams in low resource settings. If a first trimester scan is possible, do the 11 to 13 weeks. And for this, you require training. Just because you have a probe doesn't mean you can do this. And an Ayyavoo screening, which is an advanced screening where you're looking not just at the PAPE, but you're also looking at the PAPE as well as you're looking at the placental growth factor. So the low PAPEs are predictive of FGR, but if the uterine artery Dopplers are high, low PAPE and a high mean arterial pressure, and along with the Esprit trial, if you have got a positive result, please start off with 150 milligrams of aspirin if it is not already started. And this is to be taken at 8 or 9 o'clock at night. And remember, you can use other biomarkers too. Encourage regular follow-up, domiciliary BP monitoring. Don't just shove them off. Monitor these patients, monitor fetal growth, and impress upon them that they may need an early delivery. So they should come regularly for the follow-up. And finally, once they've delivered, talk to them about contraception, lifestyle changes, particularly obesity. Typically obesity, PCOS. These are the patients who are also probably on statins before they've got pregnant. These are the typical patients who will develop convulsions, preterm convulsions, as well as atypical, preeclampsia and convulsions. So remember, Maxulf is a fantastic drug. Again, these charts I'm telling you about, please take a printout, put it in your labor wards. And don't forget, this is a superb, innovation which has come, and it is not expensive. Think about this. Thank you very much. And once again, thanks to the AMOGS team, Dr. Pardesi, Dr. Sujata, and Dr. Pratik for giving me this opportunity. And thanks to Dr. Bharati Maheshwari for chairing my session. Thank you.
Thank you. Thank you, Dr. Suchitra, madam. It was really excellent lecture. Each and every word was useful. And really, it was very comprehensive, practical, very useful. And I think nothing left to say by anyone else. Everything is covered. And the last two lines, just I want to highlight that many all residents and all postgraduates, they are just attending this, and we see lots of eclampsia, preeclampsias daily in in UP and in the other areas. They are still there, and even from periphery, they are not having so much of care what they should get, and they are referred in the bad position. So I always say that we are encouraging and we are emphasizing. Then first, as you have said, that every pregnancy should be planned. So before pregnancy, preconception care really have role in the prevention, the complications, eclampsia, as well as managing the chronic hypertension. Blood pressure should be controlled before pregnancy. And second thing, we almost remain alert for the high risk cases and how we should monitor and do surveillance so that further complications can be minimized. And as madam you have said that we we are at the periphery Muzaffarnagar, we are having the now 15 beds very good obstetric HTU. So government is doing very well, and NMC has done the clearly guidelines that every hospital should have. So this is really boon to us that now such patients we get good emergency care, as well as you said, that it is really eclampsia and such complicated cases we are doing with multidisciplinary approach. So they should be referred timely if we don't have, and then we should have a good critical care of these patients. So, and what you have told about IV mag and like MEC-self kit and eclampsia kit, so that is very important, because when patients come in emergency, then the initial treatment, that is very important, how we give in time and how quickly we give. So that is very fantastic. So again, thank you, Dr. Pratik Tambe, that you have invited me, giving me opportunity to, listen the two good lectures and giving opportunity, inviting to sharing this session. Thank you.
Thank you, Dr. Bharti Maheshwari, and hats off to Suchitra madam. Dr. Suchitra Pandit, for those of you who don't know, was the person who co-opted me into the Mumbai Society. And thanks to her for giving me this platform. That's why I'm here in front of all of you today. All of whatever my journey has been thanks to her as my teacher for giving me that first opportunity many years ago. I'm sharing my screen, and here on the screen, you will see the Foxy ICOG Gestosis score, which is part of the Foxy ICOG GCPR, which we did in association with Dr. Suchitra Pandit and the Gestosis organization. This is the score which was devised by my dear friend, Dr. Gorakh Mandrupkar from Islampur. We will have him one day probably to talk about this Gestosis score in a future activity. Of course, this was validated and devised by an expert committee with Dr. Sanjay Gupte sir, Dr. Suchitra Pandit ma'am, Dr. Alpesh Gandhi, and Dr. Girija Bagh, along with Dr. Gorakh Mandrupkar. So this is the score, as madam rightly pointed out. It's already available as an Android app. It's there on the Play Store. This is the committee which was instrumental in forming this entire GCPR, and this is available for free download on the Foxy website as well as on my website. I think there is a small announcement from the Science Integra team. Can you please go ahead and share the screen? So this is breaking news. We have over 130 questions that are waiting for our eminent speakers, and we have a record registration of 1,245 audience, not only from India, but from across the world. So my hats off to the entire Science Integra team, Subbu, Sana, Ganesh. Thank you for all the hard work and effort that you've put into organizing this program, not only during the event, but also in the back end. They worked very hard to disseminate the information about the entire program. And of course, our academic partners, Blisson, who are the manufacturers of IV mag. Before we go on to the questions, if Dr. Sujata Dalvi would like to make any comments, I see she's still logged in.
But I think, Pratik, everybody has already made a proper comment. So it's okay from my side. It was an excellent webinar. That much I can just tell you. And lots of information given to those who have logged in.
Thank you so much. So we'll just take the questions which are relevant. Many of the questions which are there have already been addressed by our eminent speakers. I'll just pick up a few which have not been addressed during the talks. One of these is from Dr. Pooja Baranwal from Amethi, and she's asking, is there any role of prophylactic dose of magnesium sulfate in severe PET? I think what she's trying to ask, Suchitra madam, is about intercurrent eclampsia and intercurrent magnesium sulfate, which we used to give once upon a time. Is there any role for it today?
No, intercurrent eclampsia, now we don't believe in that. But what probably she could also be meaning is, referring to the MAGPIE trial, which I talked. If the patient has got severe preeclampsia, we can give prophylactic MAGSULF. You give it the same way, the loading dose, and follow it either the Zuspan's regime or the Pritchard's regime for 24 hours, because this will prevent eclampsia. Today, if the patient has got severe preeclampsia, I am treating her. But if she develops convulsions in front of me, then somewhere I have faltered in my treatment. So I must give her MAGSULF. So that if that is what she's meaning, yes, you can give prophylactic MAGSULF, but intercurrent eclampsia, now no. Once a patient is convulsing, you have to deliver her. There is something grossly wrong in the pathophysiology, and it's better we deliver her rather than continue the pregnancy.
Thank you, ma'am. The next question is for Dr. Charmila, ma'am. This is Dr. Mayuri Shinde Joshi from Amarner, and she is asking, what are the basic investigations which can be done in a low resource setting in rural places for patients to triage hypertensive disorders?
Every system has to be investigated. So if you want to do only for a liver function, AST-ALT for the liver enzymes, because after that elevates, then only the bilirubin goes up. So that enzymes you should do. A platelet count is mandatory. Platelet count is normal. You need not do a coagulation profile. A complete blood count is mandatory because you need a peripheral smear to see whether any hemolytic complications have started. So a CBC, urine albumin that we have in most of our centers, we're not able to do the spot protein creatinine ratio, at least a urine albumin for the renal, for the hepatic AST-ALT, and for the hematological system, a platelet count. If the platelet count falls, then you have to go for the entire profile, and a coagulation profile is also mandatory at that point.
Remember, during my residency days, 25, 30 years back, we had a registrar who used to make us do BTCT serially, yes, almost every 2 hours, 3 hours, because getting access to fibrin degradation products and platelet counts sometimes in periphery becomes quite difficult. So it was a simple, easy bedside test. I don't know how relevant it is today.
The clot retraction also we do.
It's a better test.
Append and check.
This is from Dr. Muhammad Habibul Haq. He's from Guwahati, and he's saying that in rural areas, sometimes patients don't want to get admitted after giving them oral labetalol if the BP doesn't fall. Then what medication can be prescribed? I think it's probably an indication for admission.
Absolutely.
And a referral to a higher center.
And yeah, and you have to titrate the dose. One single dose of labetalol cannot control the BP. It has to be titrated. And sometimes even with labetalol, you don't control. So you have to add on nicardipine or nifedipine depending on the situation. But admission is mandatory. I think, a lot of public forums have to be there to tell women that the incidence of hypertension, diabetes is so high in our country. So they should be, made aware that in case, lifestyle changes are important, but in case an admission is required, don't worry about that because your life is more important. Once you live, you can give best to your family. I think there's always the cost issue, which they're worried about, transport to another place. But, then this at the risk of losing lives. I feel bad today when we are still having maternal deaths due to eclampsia.
We did a data collection of rural health women here in self-help group women, the age group of 25 to 40, and we picked up 30% undiagnosed diabetes and hypertension. That's a high in the rural population. It's not even urban.
Not even urban.
Self-help group women who work physically. There's a 30% incidence of diabetes and hypertension. So you can imagine the problems which is happening in the rural areas.
Yeah.
Diseases of the modern age. I think that's what
and NCDs are very, very high in India. So we have to work on a war front, absolutely war front to get these. both these problems. And Pratik, I wanted to mention over here, today when we are talking PCO as a problem, PCO is actually an underlying problem of a metabolic syndrome. That metabolic syndrome where, triglycerides are high. And these women, again, if obesity is there, even if they're not obese, even if they're thin, the incidence of preeclampsia is found to be higher. That correlation, there's a lot of work going on this, but even in our gestosis called PCOS is one of the risk factors.
Yes, ma'am. And in fact, last month I was reading about adolescent PCOS, and there are many patients who present with acanthosis nigricans and metabolic syndrome as the presenting symptoms of PCOS. And those women, when they go on to get pregnant, they are going to have probably 10 or 20 times greater high risk factors for not only gestational diabetes, but also for eclampsia. So now we have this question from Dr. Prerna Chandak from Akola. She is originally studied in Mumbai in SIAM. I remember her. Her question is how to manage severe oligohydramnios at 26 weeks in PIH patient. Charmila.
Oligohydramnias, once you picked up fetal growth restriction, it becomes Doppler management. So if the mother is doing well, you have controlled her blood pressure, she's not gone into severe any organ dysfunction, you want to continue the pregnancy, the management of the baby will depend on the Doppler studies. If there's going to be a reversal or it's going to be bad for the baby, you need to deliver her. Other than that, for growth restriction, you don't have any particular management which will prolong the pregnancy. It's just like you want the baby to survive, so give steroids, give Maxelf, which below for 34 weeks, and see how the mother is controlled. Mother is not controlled, the mother takes precedence, so she will be delivered. If the mother is doing well, the baby's Dopplers will tell you when you're going to deliver.
Thank you, ma'am.
Pratik, I'd just like to mention here that, when the Dopplers, in the urban setup, some of these fetal medicine people are so good at their Dopplers. So they have gone into a completely different classification. Even at the first, second, and third centiles, we're able to prolong pregnancies with small babies just because their Dopplers are doing well. There is no evidence of fetal hypoxia or, there's no acidosis. And they say, okay, now the point of delivery will be determined by ductus venosus or by the change of the CPR. So, those are of course, these are not available at all places, but those really help. And just to add on one more thing, I know what Charmila says is very right, that there's nothing else which is available, but we still use a lot of L-arginine and, left lateral position, tell them to improve their diet, tell them to, thoda sa change, whatever that can happen. It means small studies have said that L-arginine helps. We don't have a big RCT to say that, but for the want of something, please, that can be tried for a little when you want to buy a little bit of time.
And Dr. Samatharam talks about hydration therapy. He says drink lots of water and it will flush out the immunological substances.
Yes, Samatharam had talked.
And he has done actually it seems to be an RCT as compared with a placebo. So probably lots of water in a low resource setting. Ask them to drink from the early days only. He says he gives them bottles of water and they have to make sure that they finish by the end of the day. Probably.
Those of us who work in ART, we are very fond of sildenafil, especially when it comes to fetal growth restriction.
Right.
There's this question from Dr. Vijaya. She's from Chennai, and she's asking the role of placental growth factor in prediction of preeclampsia. I think, Suchitra, madam, you mentioned this in passing.
Yeah. It's important to, today the Ayyavoo screen, the advanced screen is available with some of the companies. One of them I know is Lilac has got that. They look at the PLGF factor and they actually calculate and tell you this is the risk of, preeclampsia in the pregnancy. So it is important to do that because a placental growth factor does start dropping in preeclampsia, pregnancies. So quite a few times they do a ratio of S-FLIT versus PLGF. And then, that ratio will tell us what is the predictive factors. It is converted into multiples of median, that is the MOM factor, and that will give you a risk ratio. So that is, of course, where it's possible. Now in Mumbai, in Delhi, in bigger places, it is available. It costs about 2,000 rupees for that entire test. And if you're doing the first trimester screen, it'll, there'll be an additional, if it's 5,000, it will be an additional 2,000 more. So 7,000 rupees and that entire Ayyavoo screen is available. In Ireland, where they've done the Parrot trial, they are trying to see if women can be, at the emergency room itself, whether they can do this test and find out whether these women should be admitted or whether they can be sent home. And they found that when they do the PLGF ratios, if they find that the value is less than 38, then you know that they can wait for a little more time. But if the values go beyond 55 and 60, then they know that these women have to be admitted and they should be, you know, vigilantly monitored for signs of preeclampsia and delivered as soon. But, you know, the Parrot trial, the Parrot 2 has now come in. So we'll have to see what the results of the Parrot 2 trial are.
Thank you, ma'am. That's something which even I probably need to look up because I've not heard of it, very honestly. What I'm aware of is this FMF, Fetal Medicine Foundation first trimester prediction model, the one which talks about mean arterial pressure,
yes,
uterine artery, PI, and the placental growth factor. And they found that the first trimester, they have more than 90% prediction thanks to using this. And this is validated data from good RCTs. So maybe that's also something that we can easily implement and should not be all that expensive, rather than, you know, just relying on that rollover test and all those ancient tests which we read about during our undergraduate years. One last question we'll take, and this is from lost it here. Yeah, this question is regarding giving oral magnesium antenatally to prevent preeclampsia. Is there any role for it? Charmila, can you throw some light on this?
No, I don't have an idea of oral magnesium for...
This is Dr. Monica from Lucknow, and she's asking, is there any role for this to prevent hypertension? Because calcium, of course, we give.
What has been said, you know, WHO has said, calcium poor setups, meaning the resources where the diet is deficient, you give calcium and magnesium combination together, 1.5 to 2 grams, and that will help, along with the low dose aspirin, that will help in reducing the preeclampsia. But it is not an individual magnesium alone, it is a calcium magnesium combination which is given.
Okay, that's something which I think we can think of, because it would be easy to implement that actually.
Only thing is that the tablet becomes very big.
But during COVID, we took magnesium, no, madam. Actually, my nails and all improved.
Yeah.
I don't know whether it has any significance.
Yeah.
I think all of us have taken tons of zinc and vitamin C and whatnot during COVID.
But as
you know, when we were postgraduates, people used to talk about Maxwell enemas, but I don't think it's got any role. That was more historical than anything. I've never seen a Maxwell enema being given.
Neither have I, honestly. So I think that's the end of the Q&A session. If anybody else has any comments they'd like to make, then please go ahead, or we will propose the final vote of thanks. Dr. Bharati, Dr. Suchata, any of the faculty, if there's anything else you'd like to say before we close.
No, Charmila mentioned about metformin. So again, you know, that goes down to the same, the metabolic syndrome, where metformin gets, you know, it's better for conception, and once the patient conceives, you continue it because it helps the placenta and eventually probably reduces the preeclampsia. It's a wonderful study which has come with dydrogesterone. So dydrogesterone, in fact, 2 big studies which have come from Israel, where they're saying that the use of 30 milligrams of dydrogesterone, that is 10 milligrams 3 times a day, improves the placental blood flow and actually has a pro-angiogenic effect and reduces the incidence of preeclampsia. And they have done it in about 84 patients, where they've got 40 in each arm. And they found that the arm which is getting dydrogesterone versus the arm which is not getting dydrogesterone, the incidence of preeclampsia was lesser. And the second study was where they give dydrogesterone to women who had high risk factors for preeclampsia, like previous history of preeclampsia, obesity, history of PCOS, or where they were chronic hypertension. In those groups also, they found that this was much more better. Of course, the sample size is smaller, but I think there are people who are looking into doing a larger RCT for this. But dydrogesterone also, you know, probably may be an answer to our, you know, multiple things which Charmila has given, statins and, you know, protein pump inhibitors. Maybe dydrogesterone could also be an entry over there.
And then assisted reproduction.
Disease of immunology in the first trimester, and that is how dydrogesterone works indirectly. Yes, Dr. Charmila, sorry.
In assisted reproduction, it's better if you go for natural cycles for transfer rather than the artificial cycles where you prepare with estrogen and progesterone, because that has created a big number of preeclamptic cases. So giving probably a natural cycle where you can just do an artificial, like one HCG, get the egg rupture and then do your transfer. Probably you can reduce the hormones which you give. So that will be one method of management.
Thank you, ma'am. So I'll propose the final vote of thanks as the convener for today's program. It's my pleasant duty to thank our AMOGS office bearers, Dr. Rajendra Singh Pardeshi, our president of AMOGS, our secretary of AMOGS, Dr. Sujata Darvi, both of whom were physically present for the program. Thank you very much for being here. Our ICOG office bearers, Dr. Lakshmi Srikhande, chairperson of ICOG, Ashok Kumar sir, secretary of ICOG. Thank you so much for the ICOG credit points. For the first in the series, the experience series, which we have started this year in 2023, hypertensive disorders in pregnancy, updated management strategies. Thank you for the excellent talks and thought-provoking ideas. Dr. Charmila, our Vice President-elect of FOXY, Dr. Suchitra Pandit, my mentor, for giving us so many practical hints, tips, and suggestions on how to deal with eclampsia. Dr. Bharti Maheshwari, thank you so much for being here and gracing the occasion, giving your valuable inputs as well. I need to place on record my gratitude to the entire Science Integra team led by Subbu, Sana, and Ganesh. And last but not least, our academic partners, Blisson, makers of IVMAG and Injection I3. Thank you for placing your trust in us. Thank you to the audience who logged in from not across India, but all over the world. More than 1,250 of you. We hope to see you very soon in the next event. Until then, take care. God bless. Goodbye for now.
Thank you, Dr. Pratik, and all the speakers for very informative discussions. And really, I enjoyed. Thank you.
Thank you so much.